All right, thank you for inviting me to this wonderful symposium. It's really an honor to be here and talk to you about the pathology of Degos disease and its pathophysiology. So I'll put a timer on just so I don't go over here. There we go. All right. All right, so in the course of this talk, I'm going to review with you the histologic findings in the skin and gastrointestinal specimens in patients with Degos disease, and also consider the pathology in other organ systems, and then briefly consider some of the pathogenetic mechanisms that I have thought about over the years. So as you all know, the classic skin lesion in Degos disease is this interesting depressed porcelain plaque that has an erythematous rim. But these lesions are really evolutionary, they're dynamic. So the incipient lesion in Degos disease, in fact, is more of this erythematous raised papule. And then over time, it does progress, as Dr. Zaboulas so eloquently outlined for us, into this more fully evolved lesion that has the depressed plaque with the erythematous rim. And just as the clinical lesions are evolutionary and dynamic, so too is the histopathology. So what does one see from a light microscopic perspective when we do skin biopsies? Well, the incipient lesion is really an active endotheliolitis, and oftentimes it is accompanied by a significant and robust lymphocytic infiltrate. So this would be sort of the incipient lesion. And then, of course, with endothelial cell injury, when we expose type 4 collagen in the blood vessel, we activate the clotting pathway and get vascular thrombosis. And so sort of a later stage intermediary phase would have this active thrombotic diathesis with endothelial cell necrosis and sloughing. And then in a later stage lesion, the blood vessel, and it's primarily the microvasculature of the skin. So basically the capillaries and venules of the skin really develop this mummified eosinophilic appearance. The endothelium is necrotic, the basement membrane zone of the vessel is thickened, reflective of antecedent episodes of microvascular injury. And then ultimately, the vessels really disappear. And there is ensuing dermal fibroplasia, which is what we see in this particular field here, where we do not have any vessels, very few vessels, other than a few mummified ones with concomitant subepidermal fibrosis. And this is a punch biopsy. I'd like to say it's actually Roger's biopsy, that basically it's a punch biopsy through one of these porcelain plaques. And you can see the porcelain area corresponds to this central zone of dermal fibrosis with hypovascularity and frank avascularity with true vascular dropout. And the erythematous rim is really an active border. It demonstrates the active endotheliolitis of a variable lymphocytic infiltrate. And so that would really define the sort of reddish border that we see if one is to have a punch biopsy of one of these lesions. So in summary then, the early lesion is this lymphocytic vascular reaction with endothelial cell injury. And then we have an intermediary phase with frank endothelial cell denudement and vascular thrombosis. And then ultimately the late stage lesion really is one that's characterized by this sclerodermoid-like fibroplasia with vascular dropout. So the other main organ system that is affected in Degos disease is the gastrointestinal tract. So what about the pathology there? Well, from a gross perspective, the lesions that stud the serosa really are very similar to what we see in the skin. They also will show these interesting porcelain plaques. The actual endoscopic evaluation could be quite unremarkable, as opposed to the laparoscopic, where one would see these very distinctive serosal lesions. Now, what's fascinating to me is, despite the fact that they do look very similar to the skin lesions, in the skin, the brunt of the angiopathic changes are really the microvasculature of the dermis. Whereas in the gut, when one examines these porcelain plaques, there is a striking arteriopathy. So it really is targeting the small and medium-sized arteries. And they too are evolutionary in terms of the morphology of the lesions. So the incipient lesion is one that, again, involves small arteries, characterized by an accumulation of macrophages, actually within the vascular lumens and migrating through into the intima. There will be at this phase endothelial cell injury with some element of fibrin deposition. So that is the incipient phase. But then the later stage lesion is this very striking proliferative neo-intimal arteriopathy. Again, these are, Roger, is it okay to say that these are from you, these sections? I guess, okay, all right. So these sections of the intestinal tract show this very striking proliferative intimal arteriopathy. And so one can see how the intima is expanded by collagen, by mucin, and also these spindle cells. It is quite concentric. This is an alcium blue preparation that shows the hyaluronic acid accumulating within the intima. And this particular vessel is completely occluded by this collagenous and mucinous thrombus. And again, the late stage lesion will literally be a plugged artery, plugged with collagen and mucin with a variable lymphocytic infiltrate that ranges from being, lymphocyte rich to this scarred blood vessel. So again, just to summarize, it significantly affects the submucosal arteries and arterioles, obviously inducing ischemic injury. The early lesion is really an intraluminal and mural sort of histocytic influx of these macrophages with some component of endothelial cell injury and variable fibrin deposition. And then the late stage lesion is this striking neo-intimal fibroplasia with matrix production in the intima, and then ultimately occluding the vascular lumen by this plug of collagen and hyaluronic acid. So over and above the obliterative fibrous vasculopathy, which again is that sort of end stage lesion, is a significant degree of acellular extravascular fibrosis and mucin. So that's one other aspect of the pathology. And this is the subserosa, showing over and above the arteriopathy I alluded to, the interesting pattern of fibrosis and mucin deposition within the subserosis. That is another, integral component of the pathology, very much akin to the skin, where we have the vasculopathy, but also the ensuing dermal fibroplasia. Now, of course, these microvascular and arterial changes, as well as the extravascular fibrosing alterations, can affect other organ sites, really any organ, actually. And we've had the opportunity of studying 2 patients that have had pericardial disease, the most recent one being Ernie, and that prompted me to sort of review the literature on pericardial disease in the setting of Degos disease, and it's actually quite rare in terms of what is reported in the literature. 8 cases of symptomatic pericarditis that is primarily restrictive, and all those patients usually have a fibrosing reaction in the pleura as well. 6 of the 8 cases have occurred in young adult men, and they all had GI and skin disease for an average of 5 years before developing the restrictive pericarditis and pleuritis. And even though their disease may have been quiescent for a period of time, or at least stable, once they developed the cardiopulmonary restrictive pattern, that could be a harbinger of a more aggressive and in some instances terminal course. And this is actually Ernie's pericardial biopsy that shows a very striking hyalinizing fibrosing reaction that is very much like a scleroderma-like picture, and this is something that developed in the setting of long-standing eculizumab therapy, complement inhibitory therapy. So how do we explain all these changes from a vascular and extravascular perspective? And at this point, I'll basically go over my personal journey through Degos disease, which really started actually as a resident at the Massachusetts General Hospital. It was a very arduous residency, and I didn't really have a lot to look forward to be honest with you, but it was very difficult. And Saturday evenings, I would actually spend my time in the Warren basement in the Mass General Photo Lab right beside the morgue. I wasn't a morgue aficionado, but that is the truth. And I would scour through all the New England Journal of Medicine CPCs, and they were kept in these books with all the surgical numbers and autopsy numbers that were the sources of these really interesting cases. And so it was somewhat of a random Saturday evening exercise, and I came across this CPC from the late 1960s entitled Progressive Arterial Occlusive Disease, Palmar Degos Disease, a frequently fatal cutaneous systemic disorder. And so I had the autopsy, the patient had died. I had the autopsy blocks pulled, and I got recuts. I didn't really understand what I was looking at, to be honest with you. And I put it away in my teaching sets and actually didn't revisit the case until many years later as a much more experienced pathologist. So that was my first introduction to Degos disease. And so then we fast forwarded. I've now finished my residency, finished my 2-year dramatic pathology fellowship, and prior to that I actually did a cytopathology fellowship, all at Mass General. And I was a Canadian citizen, so I had to go back to Canada I really never intended to return to the US, but it was just an immigration requirement. And I went back to the University of Manitoba, and I worked as the provincial consultant in dramatic pathology, a very inexperienced provincial consultant. And I had a case of an Inuit woman who had metastatic small cell carcinoma, and she had developed paraneoplastic dermatomyositis. And she had a Gottron's papules, which are these very distinctive lesions that occur on the knuckles and interphalangeal and metacarpophalangeal joints. And a skin biopsy was done, and I was very confused when I looked at the skin biopsy. I saw the interface dermatitis that is very typical for a lupus-like picture, and all the textbooks and all the papers always said that dermatomyositis was morphologically indistinguishable from lupus. But what I didn't understand were the striking microangiopathic changes. There was a posse-inflammatory thrombogenic vasculopathy. There was endothelial cell injury, vascular thrombosis. The vessels looked very ill, and actually quite akin to what we see in our Degos patients. So I had to accept the fact that this was a Gottron's papule, and I now needed to realize that I needed to really expand the histomorphologic spectrum of dermatomyositis. Diseases do not follow textbooks. And so this case was a very important one for me to recognize, which is that you have to think out of the box to really advance our understanding. So I couldn't find anything in the cutaneous literature about the microangiopathy, but what I did find was that such microvascular changes were seen in the muscle in patients with dermatomyositis, where the brunt of injury was endothelial-based. The effector mechanism was C5b-dentionine in the Brenner-Tap complex. So I obviously concluded if it happens in the muscle, obviously the same thing is happening in the skin. And so that started my very fervent efforts in dermatomyositis and trying to understand dermatomyositis. And we showed that all of the patients with dermatomyositis of the skin have this microangiopathy with C5-9 as the effector mechanism of vascular injury, and ultimately published that paper. Now, about that time, Alexion had just formed, and they were trying to find diseases where their drug eculizumab could be used. And I think it was in 1999, this was published in 1996, they had contacted me about using eculizumab as a trial drug to treat dermatomyositis. Well, anyway, so this was published in 1996, and about a year later, my colleagues from Harvard from the Brigham and Women's Hospital had contacted me about a patient who had dermatomyositis, but that patient developed lesions of Degos disease. And the specific question that Henson Sao had asked me was, could you look for C59 in these skin biopsies of this patient with dermatomyositis who has this interesting Degos-like presentation? So that was the sort of next introduction that I had to Degos disease. And over the years, I did see cases and consultation. I continued my interest in dermatomyositis, and probably in the mid-2000s, it was established that in dermatomyositis, that these patients had very strong interferon alpha signatures in their serum. So there's an antibody that we can test on tissue called myxovirus resistance protein. It's a protein that's upregulated in an interferon alpha microenvironment. So I started to study MXA in biopsies of dermatomyositis, including cases of Degos disease in the setting of dermatomyositis. And we found that in dermatomyositis, including Degos disease-like presentations of dermatomyositis, that there was this very strong upregulated MXA signature in the endothelium, and somehow the microvascular injury with this endothelial cell necrosis was sort of linked with this enhanced type 1 interferon microenvironment. And so this ultimately, this whole background led to this paper on proposing that Degos disease is a C5b-9 mediated microangiopathy associated with interferon alpha. And this study included patients who had Degos disease in the setting of dermatomyositis, Degos in the setting of lupus erythematosus, and idiopathic Degos disease like Roger. And basically in this study, we conducted the C59 and MXA studies. We also did trying to find a viral trigger. We did RT in situ PCR for parvovirus. And essentially all the cases that we studied, whether it was Degos disease in the setting of dermatomyositis, lupus, or Degos disease as an idiopathic entity, they all had the same pattern. The vascular changes that I've alluded to with this strikingly upregulated type 1 interferon microenvironment with lots of C59 within the microvasculature. And it was this particular paper that suggested utilizing the eculizumab to treat this disease, just as the company had approached me back in 2000 with their small trial on dermatomyositis and the utilization of eculizumab. So, one of the questions that arises is what is the basis of the upregulated type 1 interferon microenvironment in patients with Degos disease? Well, likely in the setting of collagen vascular disease, there is probably a role for antibodies as a factor, and we also know that interferon regulatory factor single nucleotide gene polymorphisms exist in lupus and possibly dermatomyositis. So it could be a combination of antibodies and a monogenic phenomenon with a single nucleotide gene polymorphism. But also I think in the idiopathic setting, and likely in some cases of pediatric dermatomyositis, we have to consider a viral trigger as well. And the other issue is once we've established what the trigger is then to look at how it actually activates complement. So over the years, actually many years, I've had an interest in endothelial tropic viruses in the propagation of autoimmune disease, including dermatomyositis, lupus, and scleroderma, focusing primarily on parvovirus B19 and cytomegalovirus. And in our study that I just showed you that proposed, that the microangiopathy and arteriopathy of Degos is linked to C59 and MXA, we did show RT in situ PCR expression for parvo in a few of the cases. And this was a patient that was really quite fascinating. He was very ill. He developed this stellate porcelain-like plaque on the arm. He had severe abdominal pain. I mean, it's not obviously classic Degos disease, but I'd like to say, again, we have to think out of the box to understand pathogenesis and help patients, but it was Degos-like. He also had a profound cytopenia. His biopsy showed very striking endothelial cells necrosis and swelling, very much what you see in Degos disease. And I suspected that it might be related to parvovirus because of the concomitant cytopenia, and he actually had an active viremia and went from almost dying to actually improving remarkably with IVIG. So, and at that point, when I was reviewing all my cases of Degos disease for my papers and my continued research, I did pull out that case that I had as a Mass General resident, and I now examined it with a much better trained eye, and lo and behold, in the wall of the gut were stromal cells that had clear-cut viral alterations and really looking like measles virus, which of course is endothelial and has also been implicated in neo-int'l proliferation. So what role does interferon have in the activation of complement? That's the next question. Is complement activation in Degos disease, which we know is critical for at least endothelial cell injury, is it triggered by interferon alpha? What we can say is that the MXA, which is that marker for interferon alpha, and C59 in vessels, they have a parallel distribution pattern. There also is evidence in the literature that if you inject interferon, that site can have cutaneous thrombosis. Patients who receive interferon alpha to treat various diseases can develop retinal hemorrhages. They have high serum C5 levels. And we also know that type 1 interferons are able to activate the mannose-lectin binding pathway. So I think there is enough evidence to suggest that interferon alpha, and it being upregulated maybe through a viral mechanism, an antibody, maybe a single nucleotide gene polymorphism, can likely trigger complement, and they would work synergistically. Well, this led to a paper that really, Roger was the patient in this paper, and it was basically, as he continued to be symptomatic, if in fact the whole story could be explained by complement inhibition, then eculizumab should be able to cure the disease, and we know that it doesn't cure the disease. And so this is a very important paper in understanding what aspects of the pathology were improved with complement inhibition and what aspects of the pathology were not altered. And the inflammatory component, the lymphocytic component, the mucin deposition in his skin biopsies were not altered by eculizumab. But what was altered was the thrombosis and eventuating into the porcelain plaques that was markedly diminished. In the gut, what was not altered really significantly in the setting of complete complement blockade was the proliferative neo-int'l arteriopathy. That really was maintained. The actual active endothelial cell injury component of the arteriopathy was halted. And when you look at the intima, it was infiltrated by CD14 positive monocytes, the spindled cells of a classic myofibroblastic phenotype, showing smooth muscle actin staining without desmin, and likely those smooth muscle actin cells are trans-differentiated from the CD14 positive monocytes. So we know that the obliterative arteriopathy is largely independent of C59, but interferon alpha could certainly be a contributing factor. Interferon alpha has been associated with a diminished endothelial cell progenitor pool. It can also recruit monocytes into the intima and induce that transdifferentiation into a myofibroblast. Now this is Ernie's pericardial biopsy, showing striking hyalinizing fibrosis looking very much like scleroderma. So I wanted to understand if in fact the spindled cells had a scleroderma phenotype. And the fibroblasts in scleroderma typically elaborate smooth muscle actin and do not show CD34 staining. And right in this zone of smooth muscle actin staining, the CD34 is absent. So basically, this sclerosing pericarditis, which developed in the setting of eculizumab therapy, has an interesting scleroderma phenotype. So basically, the enhanced collagen synthesis with a turned-on myofibroblastic phenotype resulting in the obliterative arteriopathy and fibrosing reaction in the serosa pleura and pericardium are largely independent of complement activation. And so what I would say is that perhaps these pro-fibrogenic pathways that are clearly operational and not dependent on complement may be similar to those implicated in scleroderma. So I will conclude by saying that high levels of interferon alpha and complement activation work synergistically in mediating thrombotic microvascular disease in the setting of Degos disease. The fibro-obliterative arteriopathy could be linked to the effects of interferon alpha and the endothelial cell progenitor pool with monocyte recruitment into the intima, and possibly, and there's nothing really to prove this, but pro-fibrogenic pathways similar to those seen in scleroderma could potentially contribute to the proliferative arteriopathy and extravascular fibrosis. Thank you.
Thank you for an outstanding presentation. We have time for one quick question.
Yes.
Very, very interesting. Thank you. So lesions are immune mediated. That's right. Lesions are immune mediated.
Yes, yeah. I mean, whether it's not necessarily antibody mediated, right?
So it's not that the vascular enter necrosis and then attract the immune system. Is that there are some insult induced by the immune system on the cell.
Right. So I think that the endothelial cell injury in the setting of dermatomyositis and scleroderma and lupus, when patients develop Degos in those settings, I think it's anti-endothelial cell antibody mediated. I think when you look at the idiopathic setting, I think that some of these patients might have gene polymorphisms for interferon, like Roger had a very high interferon alpha signature in his serum. And then I think you have an insult, like an endothelial tropic viral infection. And then I think interferon alpha activates complement and causes endothelial cell injury. And there probably is other mechanisms that are involved in pro-fibrogenic pathway upregulation. But I think in the idiopathic setting, instead of it being adaptive immunity, it's kind of more of an innate, probably more of the innate immune response.
Can I quickly throw in a question at this point?
Yes.
Why do we not treat Degos patients with JAK-STAT inhibitor?
Right.
Can you repeat
very
the question? Repeat the question, please.
Why? So there's indication that interferon plays a key role in the pathogenesis, probably upstream of membrane attack complex. Right. So why do we not treat patients with Degos disease with JAK-STAT inhibitor? Now, not that long in the market, but you do see many interferonopathies going from children to adults, which are very effective.
Thank you.